I'm Justin Bruton. I'm an assistant professor of emergency medicine and palliative medicine at Wake Forest. So my time in emergency medicine and palliative care and had some practice experience in EMS. It's an area that I'm passionate about. I'll be also co-presenting.
And my name is Ken Hansen, and I was affiliated with an academic program in Michigan, Michigan University. And then since doing a fellowship in hospice palliative care, I kind of left emergency medicine and I've been doing that full time.
Maybe a quick show of hands. Anybody here palliative care specialty trained? Just to get us, we have a handful. And anybody EMS fellowship trained? Thank you. And everybody else is just kind of experienced.
Untrained.
Trained.
Plays in all those spaces.
Yes. All right. Well, I think we're going to try to do, whenever we do presenting, there's always going to be a little bit of hiccup. And this podium is remarkably high, and I'm not that short, so I apologize. I'll try to be on my toes here. So we'll kind of go through a scenario here that I think everybody can probably recognize, because I'm guessing most of you are emergency physicians in one way or another. So on one of these, you'll have a 72-year-old patient. This is somebody who has terminal COPD. They develop respiratory distress. Perhaps they had a pneumonia. Patient gets markedly more distressed at home, and the family member will call both their hospice care provider as well as EMS. And the hospice will be a little bit delayed getting there. As we probably all know, they're not always positioned to be there very quickly. However, EMS gets there rather quickly, like they usually do and should. Since the patient is in distress, the paramedics end up sort of managing the patient, not really clear about what does DNR mean. They don't have a bracelet, what's the pulse, et cetera. There's some confusion with that because there hasn't been a lot of groundwork that's been laid down. Patient gets transported to the hospital. Now, they come into your shop. You're the emergency physician there, and you're trying to sort of manage the immediate medical issues, right? You realize quickly that you're going to be moving towards more comfort care, however that's defined. But in the meantime, there's a whole lot of resources that are being spent for that patient. You're trying to get social work to better understand, maybe get a family member, looking through records, exactly what was their goals of care, when was that conversation last, is there a DNR, what does it exactly mean? Finally, you kind of get things squared away, and you realize you're going to try to get this patient out of your ER because it's, Friday afternoon at 4, and it's busy. And now all of a sudden it's going to take you several hours to try to get a patient either to an inpatient hospice unit or back home. Ambulances are busy, et cetera. So you all know the drill, right? The patient ends up dying in the emergency department after a lot of your time, but then also a lot of resource and capital that's used in that emergency department. Right? So it's not just your little sliver of time, it's the whole impact of the system. So the other side of this is going to be a different scenario. So this is another person with advanced cancer. Same symptoms develop. This time, family calls both hospice and EMS care. Hospice is still going to get there in a little bit of time, but EMS gets there quickly. They start managing symptoms. There's a seamless handoff already established between the hospice program and EMS. Symptoms are better managed. Hospice takes over the care at the home. EMS goes back in service, right? Patient ends up, let's say, dying at home, which was what their goal was initially. So you can see how, similar situations happen, and this happens across the country and in your ERs, that at least for the first scenario that you see every day, right? And the question really is, how do we sort of change the model to a way that is not only patient-centered, but also system-centered as well. And I think one of my colleagues will talk a little bit about a larger national agenda around EMS care, so I won't steal the thunder. So I think I'm really thrilled because I was sitting here since about 12 and there was like no one in the room. So I was a little worried that it would just be the three of us and Justin's sister who's stuck here with him basically. But it looks like there are more. So that tells me that everybody here has some particular interest in this topic, whether it is supporting a friend or a sibling. Thank you, my MCW colleagues. I appreciate you here. So if you're an EMS, if you're involved involved in EMS as a training person, you'll see that this kind of agenda is making its way into local, state, and even some national curricula, both in a formal way, but in an informal way, like some of the work that some of us are doing and others. If you're an EMS leader, as one of our colleagues here is, and a few others, this is really a great opportunity to think about how does your EMS system intersect with hospice and the healthcare system, right? Because I firmly believe that the decision that happens in the field, where that patient is brought to, really significantly impacts their outcome. So all of us know this from working in ERs. You have a train wreck of a patient that just had their gallbladder taken out and their septic from a different hospital. They show up at your place, right? So there's a lot of work that needs to be done in that area. For the palliative care groups here, certainly I think this is a great opportunity to think about how do you tap this resource to help to manage some of the palliative care goals. And I would really contend, if you think about it from this way, EMS is perfectly attuned to identifying and managing symptoms, right? They have a broad communication network. They're available 24/7. And unlike most of you, they're used to delivering care in a patient's home every day. So this is a natural alignment that I think we really should take hold. And then this last bullet point about if you're a health system leader, I think it is really important to understand that there is an economic driver behind all this as well. So not only does it make sense, from the patient standpoint, but it makes sense from the health system standpoint as well. Now, I'm going to step back for a moment, and hopefully this is not too elementary, but I think just to level set here, because I do see a sort of a variety of learners here, some grounding definitions, right? So palliative care, certainly the who in palliative care is the patient who is really facing a life-limiting disease. And what that sort of model entails is managing not only their symptoms, but really the quality of life and all the things around it, social, spiritual, financial, and others. And then the other component of this, of course, is the family, because rarely these patients are, by themselves, right? So that's the palliative care sort of definition. And we hear hospice every day. That patient's on hospice, right? Really? But at the end of the day, we need to really understand that hospice is nothing more than an insurance definition. That's really what hospice is, period. And the criteria of that, of course, are if somebody is prognosis, they have a life-limiting condition, their prognosis is less than 6 months, so therefore Medicare will pay for certain care, and the focus of that care is only around the kind of quality, comfort, those kind of things. It excludes a lot of things, like aggressive care, chemotherapy, and other things. It also excludes transportation. Right? So if you are an EMS person, or if you're a family member, this will be money that will not be reimbursed if you're an EMS agency. So either it's got to come out of somebody's pocket, whether that's going to be the palliative care who may have a contract with an insurer to manage their care. So it's going to come out of that pocket. It's going to go into the taxpayer pocket, or it's going to be transferred to a patient. And, I don't know if you've seen ambulance bills lately, but they're upwards of $1,000+ per transport. So there's a lot of implications around that. Now, I think everybody understands some of this. Because you're here, it tells me that you understand that there's some value to palliative care and hospice care, right? There are good data that suggest using this model is effective in a lot of different ways. It clearly reduces aggressive interventions. That's the point, right? It helps to, and as a result of that, and as a result of things like utilizing hospitals and emergency departments, it reduces the cost to the health system and to the patient. And then on the other side, of course, it improves the quality of people's lives, right? If you ask most people where they prefer to die, and there's some really good data out of Canada, if there are any Canadian folks here, I envy your, I'm looking at some of the programs in Calgary and in Nova Scotia around the MIH model, and we'll get there in a bit, but I think what you're doing there is phenomenal, actually. But so if you ask most people where they want to die, they would prefer to die at home as long as their symptoms are managed. That's kind of what we understand from the data. So I think a lot of these reasons, it's important to understand that this is a natural place for EMS to be able to be a part of. Now, again, hopefully this isn't too basic for some of the folks here, but traditionally we think about the organization of hospice and palliative care into this dichotomous model. And I guess I would argue in some disease conditions, so if you have a gunshot wound that goes through both hemispheres of your brain, this probably identifies that, right? So you have some life-prolonging care, and then a clear boundary happens, and then it's a shift towards palliative care and death. So this disease progression can be abrupt, right? Or it could be something longer, and then the patient dies. So this is sort of an old model most of the time for most disease conditions. But I think this is a better model, and there are a couple others that have some better color to them. But essentially this model talks about this as a continuum of care. So from the time a diagnosis occurs, the focus, as it should be, is generally on curative or therapeutic interventions, right? That's the goal. You have an advanced cancer, you want to try to figure out, can I get some cure from this? But you'll also see that there is, ideally, sort of the initiation of some palliative care in there. So while you're managing chemo and radiation and all of that, hopefully somebody is helping to start manage some of the symptoms and asking the bigger questions are, and that is, what are your goals of care, right? Because I think there could be a lot of conflicts of interest, if I'm honest, if you're entirely in this space, right? Clinical trials, revenue from these kinds of things. So I think having a person or people that focus just on palliative care would be advantageous. So, in the process of dying, then you'll see the curative starts to wean down and more of the palliative care happens. And then when you're at that magic 6-month marker that's set out by insurance, you enter into that hospice insurance phase. Death happens, but then you'll see here, there's also this opportunity for palliative care to support the bereavement process for families. Remember, this really is a family-structured approach, not just necessarily patients. So I guess there's probably a couple opposing philosophies, because the first time I introduced this concept of using EMS in palliative care, people think of it as these cannot be further from each other. And the same, I would argue, from emergency departments. But actually, if you think about it, most of what we do every day is some form of palliative care. And I love the generosity that our formally trained palliative care docs say that we're all generalist palliative care doctors. I appreciate that. So for the ER docs that are not formally trained, I love that. But EMS traditionally focuses on managing some acute life-threatening diseases, so trauma, cardiac arrest, that kind of stuff. They focus on kind of managing symptoms, and then they're generally a go, no-go mentality, right? So red light, green light, that's kind of where they always stay. Now, that's traditional, and there are a lot of models that are evolving around community EMS and some other things that we can talk about another time. And then, on the HPM side, again, that's around the symptom and quality of care, basically. So for the reasons I illustrated before, I think EMS is perfectly positioned to get into this space and not necessarily compete with palliative nurses and home hospice. There's a role for all of these people there. And what do we know so far from the data? So from the data, most people that are enrolled in a hospice program enter back into the healthcare system formally. So upwards of 80%. So there's clearly a failure in that. And when I think about this, I think about this is essentially a failure for us to prepare a patient and their family for the dying process. That's what this really is at the end of the day, right? So that's why I feel like it's on us. There are a lot of encounters that we have through EMS where we can do things like care at home, treat in place, and then also other things like transport to alternate destinations. Remember that while hospice is an insurance benefit, ambulance actually is an insurance benefit. We think of it, of course, as a healthcare delivery model, but at the end of the day, most ambulances will not be reimbursed if they do not transport a patient. They might get some marginal reimbursement for doing things like resuscitation at home, but if they're going to stay there for an hour or two and manage somebody through sort of the terminal death process, they won't get reimbursed for that. So there's a misalignment of incentives here, right? So this is where I think as leaders we need to get in there and think about how do we find different ways to do this. And I think most concerning, and I hate to say probably as I'm looking maybe around some of the room, we're starting to enter into, I'm not quite a boomer, but we're getting into this space now where we're going to almost double our healthcare expenditure on hospice care, upwards of $67 billion. And that's staggering, actually. So I think for me, this is a call to action. So with that, I'm going to send it over to Justin.
So we've all inevitably had that hospice patient who shows up in the ED and we're thinking to ourselves, why is this patient here? You're on hospice. Why shouldn't this be managed at home? And there's a lot of things that can happen that can contribute to family members calling. When I was in fellowship, I had a patient, the spouse of a patient with terminal pancreatic cancer who just had some personal psychological issues with the thought of her husband dying at home. So there's things that happen that lead to EMS being called despite the education that hospice may engage in to talk about code status, to talk about expectations and try to manage some of those fears. Also, I think inevitably you have that I'm gonna go out and run some errands and Aunt Betty is gonna watch you for a minute and while I'm out, that's when the patient's gonna get worse, right? And Aunt Betty's not gonna know what to do. So the part of empowering EMS is finding ways to give them the skill sets they need to navigate these situations, because otherwise they're just going to keep happening, because you've got to get that problem addressed on the front end, hopefully. And lastly, I would add too, in palliative care we see kind of that understanding of death and dying as a spectrum. So you can have a patient who 1 minute is very aware that they're dying, they're very aware of their prognosis, they're very aware of their cancer, and the next moment they're thinking about their daughter's wedding. They're thinking about something they're hoping to make it to. So it's very natural for patients, even when they are informed, to vacillate between different points of understanding. And then unfortunately there are times where they're legitimately not fully aware of their prognosis and fully aware of how serious it is. So if we think about some of the scenarios that EMS encounters, and I think back to my days in EMS, that kind of is a guide for the types of skills that they're going to need to be able to operate in this way where they can avert some of the transports that we see that we feel like are less serving to the patient and the family. So one example, I have a patient with advanced cancer and they've kind of gotten their ducks in a row, right? They did a pulse form, a Mohs form. They've talked to the spouse, they've tried to get them ready for what distressing symptoms might look like, what the dying process might look like. And they get everything lined up, and then the patient, because of his lung cancer, starts having some hemoptysis. I've seen this happen, and it's a very distressing new symptom for the family member. And they're not sure what to do. So they call hospice, and then they promptly call 911. So if we take this situation apart, what are the skills that EMS is going to need to try to change what's happening? So they're going to need to have a good understanding of pulse and MOLS interpretation. They're going to need to know how to talk to that family member. How do I tease out a true desire for transfer and reevaluation, more testing, versus somebody who really just needs guidance on the dying process, and that this is part of the dying process, and how can we manage the symptoms and get your husband comfortable? So that's a skill set with communication. It's a skill set with the local laws and state laws related to advanced directive interpretation. They need to have a skill set and they need to have orders available to be able to order medicines. One of the things that we found in trying to implement things at our state level in North Carolina is sometimes you need to get the medical direction codified for the paramedic that's on scene. If they're calling the ED and they're asking somebody over the phone, hey, this is what I've got, can I have some orders to give this patient medicine? You're gonna have widely varying levels of comfort with what to do over the phone. So you need to trust that that paramedic who's looking at that situation right then, if they have the orders that enable them to administer medication to try to alleviate some of that distress, that they can do so, and you're not taking into it, you're trying to avoid that highly variable scenario of the comfort level of the physician that's on the other end of the phone. Because I'm gonna give a very different answer over the phone than some of my colleagues will. Even if they're excellent in the department administering palliative care, their comfort level with trying to manage that situation over the phone could be very different. And then again, communication skills and options to treat and place versus having to transfer. As Ricardo mentioned, there's difficulties with reimbursement, so models need to change to help allow that. But if they are beholden to have to transfer the patient if they give controlled substances, then this doesn't work. Next, the other thing I think that we can sometimes neglect is that when people work in EMS, some of the chronic patient population that they see, they actually get to know the patients really well. One of the things I vividly remember, these are all based on patients that I took care of the cycle that you see over and over again of the patient who gets recurrent illnesses, goes to the ED, goes back to the nursing home. They see that over and over again. And so often, I know we've seen it in our departments, we'll have a family member who attributes their decline to, oh, it's the facility. They're not doing this. They're not doing that. And that family member needs some education on the natural course of the disease process. And sometimes there are actually pretty trusting relationships that can be built with EMS and people in the community just because we are in their homes. We see them on a regular basis. So can we empower our paramedics to be able to start these conversations, right? They don't all have to be physician-driven. And while we have the technical expertise to maybe explain things in more detail, that paramedic may have the ability to explain it at a level that that family member is going to understand and really get a better grasp of the situation. And just to introduce the idea that maybe we need to rethink how we're taking care of your family member. Maybe there's some other options about what we can do. So again, in palliative care, one of the things we talk about is how do you bring up bad news in a way that people are going to receive it? So there's communication techniques for that paramedics need to know. Are there partnerships with local agencies to be able to allow for referrals and allow for opportunities to initiate that process sometimes with these patients that are having recurrent visits? Because even if this patient goes to the emergency room that day, that paramedic may be starting a conversation that family member really needs to have. Also, you've got patients who, they're on that palliative care spectrum that Ricardo was talking about earlier, where they're still getting treatment. They're still getting treatment for their disease, but they're under palliative care for the symptom management associated with their disease. So a patient with significant cancer burden of symptoms that is on a complex pain regimen, that patient may not want to go to the hospital. They may still be doing their treatment, but they really mostly need to have their acute symptoms addressed. But these people can be complicated. You've got a patient who's on a chronic pain regimen, and they have a pain crisis due to nausea and vomiting. They're not keeping their medications down. You need to have guidance that works and education that helps that paramedic understand the normal medication doses you might be used to giving this patient may not be adequate because of their tolerance and their pain level. And also, do they have the ability, do they have orders, again, to treat in place? Can they get this patient's symptoms controlled and maybe avoid a transfer to the hospital for a patient who doesn't need more workup, but they need symptom management and they need something to bridge them into what they would do next. So any communication tools that we have and any educational tools we have to take into account the kind of common scenarios that they're going to encounter. Here's a brief list of the kinds of things that often I've seen paramedics encounter in the palliative care scenarios, and this is the kinds of things that get addressed in the different curricula that are out there. So acute pain and symptom management, opportunities to talk about care goals and transitions and how to go about doing that. Ways to deal with agitation, ways to manage expectations with nutrition and hydration. That comes up a lot with patients who, they're not eating, they're not drinking. And instead of, well, let's automatically transfer them to the emergency department, can we educate on really the role of that in palliative care or in hospice care? And then options, sometimes patients will have new conditions that it is reasonable to bring them to the hospital, right? They may have terminal cancer, but if they fall and break their arm, they need a splint. That's part of their pain control plan. But that doesn't necessitate, they may be able to return back to the care model they were in, even if they need our help in the ED temporarily to address that new problem. So what's the consequence if this doesn't happen? Well, a lot of patients ultimately end up returning to the hospital. They end up dying in the hospital. So out of the ones that come from hospice back to the ED, we have a high number of patients that get admitted, a high number go to the ED once they call 911, and then many of those go to the ICU, and the inpatient mortality is unfortunately very high for this population, as you'd expect. So as we're going to discuss further, there are opportunities at the national, state, and local level to address this. EMS.gov put out EMS agenda goals for 2050. And all the domains that I see here, all to me, I can see an opportunity for palliative care integration. Is it innovative? Is it sustainable? Is it seamless and integrated in the health system? So there's goals in their statement about having more person-centered care. So I think, as Ricardo mentioned before, we're seeing a push towards getting EMS more integrated, and palliative care, especially as the population continues to age, is going to be part of that. And then lastly, what are the opinions of people who have had education in this, the paramedics who've been educated? So as Ricardo was mentioning before, there was a Canadian study where there was a educational program called LEAP. It included 8 hours of asynchronous education and 6 hours of preceptor-led education. And they, after going through this education, paramedics reported much higher levels of confidence in addressing various domains of palliative care. They also universally saw the need for their personal understanding of palliative care, and that all paramedics need to be able to deliver palliative care. So I think that that's a pretty telling example of why this is needed and how we can continue to innovate in this space. And I'll turn it over to Ken.
Okay. So show of hands, who here works with EMS systems? Just kidding. So they're driven by protocols, right? And so that's really something that's important to look at when you're going to look at a whole, kind of integrated way to kind of engage EMS into hospice palliative care. So this was a study done recently and actually looked at the whole country in terms of protocols that were available. Now, the important things I think to note are 35 states had state EMS protocols, okay? So where I live in Michigan, we have a state EMS office, and so any protocols that are submitted are now available for the whole state, right? So the EMS systems are on the same protocols. We thought that was important. 14 states actually had some form of comfort care, right? We're going to recognize your DNR and not resuscitate you, if you have this sort of thing. We might provide limited amount of medications to support you. Only 3 states really had hospice protocols, right? And so that was kind of interesting data. Now, what's important in a hospice protocol? Well, my colleagues have talked a little bit about this, right? Treatment on scene, okay? Work with the hospice agency, okay? Hey, how about calling the hospice agency instead of medical control for recommendations? Morphine dose equivalents and tables that will help them calculate when a patient might be on, 600 milligrams of morphine a day, right? We once calculated with a patient, it would have taken 3 rigs to get the medication that they needed, right? Never used Narcan. Who's been on the receiving end of that? Yeah, I have. It was horrible. It's a hospice patient, somnolent, got Narcan, and then where did they bring? Kind of expanding the scope of practice, right? Accessing ports, putting in sub-Q buttons, comfortable with terminal sedation, perhaps, okay? What about the comfort kit, or sometimes called the E-kit, that the hospice agency has left on the residency, there at home? Why not use that medication, right? Because it's there for symptom management specifically. And then, other things such as non-narcotic, non-opioid use, right? Like ketamine, that sort of thing. So there has been some work done in this. There was a study done in California where they took community paramedics, did specific training, and then kind of put them into the system to try to assist with these patients. And other agencies, MedStar down in Texas, and then actually, Ricardo, you can speak to your program as well, if you want.
Yeah, next slide, I think it comes up actually.
Okay, yeah. And what they've really shown is that this can have significant effects, right? They looked at high-risk patients that this was the hospice agency saying that they were at risk for disenrollment, and EMS got involved and had significant decrease in disenrollment, right? And frequently it's because they didn't get transported to the emergency department, right? Okay, yeah, but you can go ahead and speak real quick.
So I'll give you an example. So Greenfield Fire Department is within Milwaukee County. And when I was the medical director of that agency, we had a large hospice program in that region. And they reached out to us because a number of patients were being referred back to emergency departments. And there was, risk of revocation, right? So I think, my first impression was cost savings, right? This aligns well with their needs. And do patients want this? So we did a little bit of reaching out to some of the patients to grab some consensus, like, is this something that you folks want, et cetera. We realized that there was alignment in this. So we first started with some basic training for the paramedics and the engine in this. This is a 3-station department. So we did some basic training. And then whenever patients who were enrolled in this particular hospice program called, if they were to call 911, we flagged them in our CAD system, our computer-aided dispatch, so that that would automatically call the hospice nurse on call, so that the hospice was also aware, and they would meet EMS at the scene, and then they would help troubleshoot the patient's needs. The other thing that we did with this is we allowed for transport to an inpatient hospice unit, either for symptom control, for more symptom control, or for respite care for families, instead of bringing them to the emergency department, which would have disqualified them. So, a lot of innovation around that idea, and it was, really well received there. And then I'm the state EMS medical director for Wisconsin, so we're one of those 33 states who have some statewide. They're all voluntary, so agencies can use them at their leisure, but we put some protocols out there. They're all public if you want to take a look at them.
Did EMS get paid for it not transporting, or was that just they bit the bullet?
Early on, they bit the bullet, and then later on, there was some reimbursement for that.
Was that accomplished at the state level? You were able to bring that up?
No, that was actually local level. Wisconsin is a home rule state, so a lot of these decisions are made locally. The state of Wisconsin, we lay out the scope of practice, but the operations are all left to individual agencies. Yeah.
And I'll jump in and talk about our North Carolina process. And actually, on my, if you're interested in what this could look like, I've got a website that you'll see a information for at the end. But we actually did a instructional video that kind of shows what it looks like what a scenario looks like when a family member calls, and how a paramedic might go about using our protocols, go about calling hospice, engaging them, treating symptoms, and then being able to transition and leave the scene so that hospice can take over. So just to kind of get an idea, and this is available on the North Carolina State EMS website. So obviously too small to see, but just the big picture item I want you to take away from this is it's algorithmic. Like most EMS protocols, like ACLS, right? We think in algorithms. So very straightforward, the paramedic is going to identify a patient who maybe already is on hospice, or maybe a patient who has a terminal illness, because we have the opportunity for them to engage hospice too, even on a patient who's not fully enrolled. Now that might change what happens on scene if hospice isn't involved at all with this patient, but they do have the ability, and at least locally, we do have paramedics who've been able to work with one of our local hospice agencies and do referrals. So after they identify that they have an active hospice patient, if they are going about their regular routine care, right? They're going to, COPD exacerbation, yes, do all the things for COPD exacerbation, exit to the regular protocols they would follow. However, if the patient is on hospice care and they navigate the desire to treat in place and not transport to the hospital, they have the ability to utilize medication tables like we talked about to try to go about doing that. So one of the nice things about starting with a protocol, there is an investment in trying to educate at various levels, because you've got so many different community EMS agencies. That's really got to be tackled by them, and I think many of us are in the process of working on material that can be used sort of semi-universally, but at the local level there's still some work that has to be done to kind of educate your own group. However, when you start with a protocol, it's pretty low-hanging fruit. You get the benefit of some direct information, you kind of circumvent some of the problems that may happen with medical control, what they call the ED, and get very discrepant answers about what to do. So you kind of enable them to use their judgment to be able to address matters on scene. Now, with more education, they'll probably get better at that, and that's part of where community paramedicine and investment in specific individuals who kind of show a penchant for this can be very useful and can be a very effective way to approach it for those situations that require more navigation. But by just starting with things like medication tables, you can at least give them an idea of what medications can we administer. And like, for example, we have tables that give escalating doses so that patients do have some tolerance, even if there's not a clear understanding yet with education of all the nuances of opiate management and opiate conversion calculations. They can at least give escalating doses of medicine. And the big difference is, like when I was working in EMS, you couldn't just give, this was a long time ago, but you couldn't just give controlled substances and leave the scene. So this is a big difference to be able to say yes. In these patients, when we have an established care plan, the goal is to keep them in place, treat them in place. You have the ability to give those substances if you need to get them stabilized. Because a big piece, as we all know, is once the patient feels better, the family feels better. The acute problem is addressed, you can now avoid that transport to the hospital that's not necessarily really going to accomplish anything else for the patient, but you help bridge that space between the distress they're experiencing and the need to have hospice show up and then continue to manage them.
So if we look at, actually, real quick, I will say that for the state of Michigan, we kind of went to Justin's protocols and really just, I mean, why reinvent the wheel, right? I will comment that we did run it by pediatric hospice group to look at that, to just see what their input would be, and they said pretty much do whatever the hell the parents want, right? Because if for those that don't realize that pediatric hospice patients can do concurrent care, so they can be seeking aggressive care, but also be on hospice, right? And it's a whole different dynamic with the dying child. So, so if you look at the roles, really, it's really kind of down to scope of practice. Now, it's important to realize that what drives scope of practice is, well, it's going to be the state laws, right, and regulations. So, you can't apply, from state to state. You have to kind of look at that, but there are generalities that can apply to a lot of systems. But, just basically surveillance. Gosh, this is the 4th time we've been to this residence for a lift assist. And every time they're a little bit sicker, and every time they're refusing to go to the hospital. Maybe it's time to have a different conversation, right? Screening for advanced directives. I know some agencies actually will push, hey, do you want to be a DNR? Well, then let's get that order placed, right? Let's get these sorts of things. MOLS, PULSE, these sorts of things. And then really being empowered to follow the advanced directives if the patient is actively dying, cardiac arrest, that sort of thing. And then when you get into kind of broader interaction with community support, hey, let's reach out to the Palliative Medicine Service and see, or the hospice agency, that sort of thing. And then some agencies have tried doing transport to an inpatient hospice facility if they're unable to control symptoms at home, when the option would be to go to the emergency department. And what the hospice agency can do is admit them what's called under GIP or general inpatient admission for several days to control the symptom management, right, and then send them back home. And so if a bed is available at one of these inpatient units, it becomes an alternative destination, and now they're transporting. So it's a win-win. The next level on top of that is community paramedicine or mobile integrated health, right? And there's been some good work done on that. But they'll go out and they're doing this more kind of community health based, and they can do a lot of screening to say this patient might benefit from palliative care or even enrollment onto hospice. If the patient's getting symptoms that are out of control, they can respond with the 911 unit and then stay and play and put the unit back into service, right? And then even if the patient winds up dying during the visit, they can stay and do bereavement for the family. And a lot of these programs have done extra training to facilitate this sort of care. So this was a study that was done where they basically surveyed EMS clinicians, right? And what it showed was that 70% had no education for the care of this patient population. 36% believed that hospice required a DNR. Now, does that make sense? In other words, does a hospice patient have to be a DNR? No, they don't, right? Can a hospice patient go to the emergency department? Absolutely, okay. I think Justin had mentioned, they have a fall, they've got a deformity of the upper extremity. Absolutely, the hospice agency will want them to go to the emergency department for pain control, reduction, splinting. That's a comfort thing that's going to add quality of life and comfort to them. So the idea is limited specific symptom treatment, right? Treat and put them back at home. But what was interesting is by looking at what kind of the baseline is, not only are they finding that they're not really trained for this sort of patient population, there's a lot of burnout. They get a lot of flack from the ER staff. Why are you bringing the hospice patient to the emergency department, right? You're wasting our time, right? And then they kind of feel helpless if the patient dies. They don't have the training in communication and bereavement to try to deal with these things. All right. And when you look at, I think I went too far. There we go. Nope, sorry, getting lost here. There we go. So pulse, these are pretty much ubiquitous in almost all 50 states in the United States, right? And for those of you familiar, the section A says CPR, no CPR, right? I want CPR if I do not have a pulse. I do not want CPR if I do not have a pulse. The next step down is if I have a pulse, but I'm not breathing or I'm unconscious, what to do, right? Comfort care, limited, full treatment. Well, what they did is they gave sample patients to EMS crews, and this is what really threw them off, right? The patient wants to be a DNR, but they want full aggressive treatment if they have a pulse. That just doesn't jibe with how they are trained, right? And so what you actually found is that, there was only agreement when it was full CPR and full treatment. Otherwise, they got confused. They were doing such things as holding intubation for a patient that was having respiratory distress. 40% believed that they needed to be a full code if they were, on hospice. So it's very important to kind of have this training to really bring them up to speed. There's lots of great stuff out there. Sorry. Got one more slide here. So the key components, if you're going to do the training, is pulse interpretation, primer on hospice principles, right? Symptom management. Opioid conversion is important. I think most EMS clinicians do not know how to use opioid conversion charts, morphine dose equivalents, these sorts of things. And so training in that can be really important. And then specific things such as using, say, an opioid for dyspnea is really kind of usually out of their scope of practice. The other thing is communication skills, right? Words matter. And frequently, they don't have good communication skills on how to deliver bad news and how to deal with these sorts of things. And then, having them understand the phases of dying. If they can show up to the family and say, you know what, in a very kind of palliative way, I think your loved one has minutes to hours before they're going to die, right? And that's kind of how we will do it. It's minutes to hours, hours to days, days to weeks, that kind of thing. And it kind of gives a perspective to the family. So, okay, and here's the slide I had talked about. Lots of great resources, okay? There is EM Special Interest Group for American Academy of Hospice Palliative Medicine. There's a Palliative Medicine Special Interest Group for ACEP, for ACME, CAPC, lots of different stuff out there, and it can make a difference. Here's a study that looked at, I'm sorry, did everybody get a picture of that? Okay. Here's a study that looked at basically doing a national free curriculum on Prodigy EMS, and they got close to 2,000 EMS clinicians that took this training and saw a difference in terms of follow-up communication skills as far as delivering bad news, and just the overall comfort with dealing with these kinds of patients, all right? And it was a very kind of quick and dirty education seminar that they could do online. So if we look kind of in summary, we've kind of broken this down into kind of bronze, silver, and gold, right? So if you're thinking about doing this sort of thing and initiating improvements in your system, really you got to do a needs assessment first, right? The joke is you've seen one EMS system, you've seen one EMS system, right? They're very different and they have lots of different things that you have to deal with in terms of, protocols and that sort of thing. Probably start with both not only the EMS system but the emergency department to say this is an issue we're trying to do and do education. The next step would be then to look at protocols and support those with training, right? And then don't forget about the pulse, DNR interpretation, and then really communication skills. They really do need, Justin and I spent a lot of time learning communication skills. That's a big part of a hospice palliative medicine fellowship. And then you add on top of that would be then you would reach out and do collaborative agreements and networking with palliative clinics, hospice agencies in your area, right? And you can do some of the things that we've talked about here today. And I know the Canadians are kind of way ahead of us in terms of loading up hospice patients locally into the CAD system. So as soon as they call 911, bam, EMS knows, right? So these are kind of the things that can really be, and I know, Ricardo, you've done that, so that's great. The next thing is the community paramedics, right? Mobile integrated health. They're not load and go, they can stay and play, right? They can go and stay for an hour or two until the hospice nurse shows up from the hospice agency, and then they can do a warm handoff, right? So I wanted to acknowledge two other colleagues that could not be here. Dr. David Wang and Amelia Breyer helped with this as well. And then no disclosures. So we've got about 10 minutes, I think, for questions.
I did want to add one thing. The North Carolina protocol, I think is a great example of collaboration. It was actually, the initial thought was started by one of our local medical directors that's like, I see these patients. She worked in the ED with me, and she knew what I was doing, and she's like, we need to do something about this. So we had a hospice medical director, we had a local medical director, we had our state EMS director, and we got everybody at the table to discuss what does this need to look like. So it's definitely very much a joint effort to try to create a process like this.
Absolutely. Here. This is being recorded, so you can pass this around.
Has anyone tried this with non-paramedic providers? I work in particular in rural areas where a paramedic is a really rare resource, and things like a hospice kit at home, which is generally oral or rectal or buccal medicines. Has anyone had a lower level trained pre-hospital provider engage in any of that?
So in most localities, you can't give you couldn't give controlled substances, correct, if you're not paramedic trained, because even EMT intermediates, I think, have a limited ability to give those things, even if it's prescribed medicine, I think.
Now that said.
That's variable.
That said, so in this idea of community paramedicine or community EMS, otherwise known as mobile integrated health, I'll give Wisconsin as an example. We allow those to happen both at the paramedic level, but all the way down to the EMT level. And a lot of this symptom care doesn't necessarily involve drugs, at least to start. So we do have an agency that is an EMT provider, that is an MIH provider as well. And they do some of this kind of work, but it's a little limited. But the short answer is they don't have to. And in Wisconsin, we actually, in our scope of practice, at the EMT level and above, they are able to assist patients with home prescribed medications. So if a patient is on an opioid, it requires them to have a consultation with their physician, but they can call their med control and say, I'm an EMT, I want to give whatever, and it's prescribed, is it okay? And we can manage it.
Yeah, very cool. We could do that.
Yeah.
Be hot listing for that one paramedic for a big county.
Yeah.
No, that's a good question. And, this would be one of those things where if they could stay and, acute dyspnea, hey, let's put a pan in your face, let's reposition you, let's do some other things that might help with your acute dyspnea, waiting for the paramedic to show up, or the mobile integrated health, that sort of thing. But I think, when I've been an EMS medical director, frequently it's a matter of, can I justify expanding the scope of practice with the required training, right? And that's the key. You don't want to just throw protocols at somebody and then say, good luck. You've really got to support it with the education and training and QI and all that kind of stuff. So,
Other questions? Go ahead.
I have a question about your involvement.
Yeah,
Sorry.
Sorry about that. Yeah.
Evan.
Got it? Okay. I have a question about involving the 911 system and the CAD system. I suspect that early notification of EMS and also early notification of hospice is crucial in kind of successful visits. So can you talk a little bit about how you managed that? Who updates those patients? Who takes them out when they die?
Sure.
You know, so.
Yeah, that's a great question. And I think the other part of that that people might not understand is, especially as we moved away from a landline in the house, you might have multiple family members with different phone numbers and different phones that are accessing that. Or the patient may be somewhere else, not in their home. So I think we left that to the local jurisdiction, and it was a particular hospice program, and the two of them actually helped to keep that list up. It was a little bit labor intensive. There were not a lot of patients enrolled. I want to say a little bit over 40 or 50, if I remember correctly. So it wasn't a huge population, but it was manageable for that agency.
And I'll comment on, in my EMS agency, the CAD system will display an address, not a name. So you'll know that somebody at that address is calling 911. It may not be related to the hospice patient. So
Maybe
there
as
are,
good as you can get, right?
Yeah.
So somebody at that address is on hospice.
yeah, exactly. So at least they kind of, yeah.
Thank you.
Microphone.
This is being recorded.
Sure, thanks.
I think the question that is often present that nobody wants to always talk about is funding, because there's no doubt that this is something from my paramedics I've heard that they would love to do so, but like to the point you brought up before, if they're not transporting, where's the reimbursement? I'm always a fan of hearing creative ways of how you can convince funding from the hospital or funding from the city. What was your experience in that regard?
The expression is getting blood from a stone. Is that how it is? So really, I'll be very candid here. Unless there's a financial incentive to a payer, I think most of this is not going to work at the end of the day.
There is a system in Fort Worth, Texas that has been very successful. Now they're very, very large. They basically funded it themselves for at least 3 or 4 years. When I was a medical director, we went down and looked at them. They collected data, they went to all the regional hospitals and said, here's the amount, here's the millions of dollars we've saved you over the last 4 years. You need to fund this or we're shutting it down. And they were clamoring at the doors to get this done. I mean, I think grants are great. I remember reading an article maybe 10 years ago when mobile integrated health was just getting started. And the authors went around and went to a lot of these successful programs and said, how's business? They said, it's booming. How are your finances? We're hemorrhaging money. And a lot of these wound up shutting down because the grant ran out, right? So I think that's a really important thing to get set up before.
To piggyback off of Ken's answer, and this is an area of expertise for David Wayne because he worked in the San Diego area on some of this. I can see it being helpful in a hospital system that runs its own ambulance service because the savings have to be in the same bucket, right? I can see a county service having trouble or a privately run service having trouble because they have no incentive. But especially when you have a big hospital system that runs an ambulance service or is contracted to run an ambulance service locally, I can see it working because they know that they're going to, the reimbursement they would have lost in the hospital, they'll make up for the cost they would have had in the hospital by not transporting that patient and dealing with the situation at home.
So you're going with the less negative approach in the sense that you've lost less money because you're not getting bounce backs?
Correct. You're not getting, because that has implications on, and I could also see even a hospital system that's not affiliated with EMS, I could see them being interested because they still get impacted by the bounce backs, right? Because this person that we worked in palliative care to get on hospice while they were in the hospital, if EMS isn't helped out with this process, they're going to come back and you're going to get dinged on that admission. So I think as long as you can you have to tie the incentive to the financial risk that they're going to take if they just let things be as they are.
Okay.
So,
Thank you.
yeah.
My question is, so in Connecticut, the EMS system, whether it's private or AMR versus hospital-based, that actually ambulances, regardless of funding, they're actually not allowed state regs. They have to bring the patient to the hospital. They actually, because for example, we have the Yale Health Plan, which is the infirmary. It's a big place where we would have liked them to bring the drunk students, for example. When they pick them up, they can't. They actually have to bring them to a hospital. So do other states have those types of regulations that would prevent a patient from being brought directly to a hospital?
I can speak to that from, again, I'll use Wisconsin as an example, but others as well. So we change our legislative rules. It used to say hospital, now it's healthcare facility, and that could be more broad. But remember, the driver behind that is reimbursement. That was the driver behind that. So I think there could be ways to get around that.
And I'll speak to that real quickly. Other initiatives being done for behavioral health and also opioid addiction, right? So a patient is in crisis from opioid addiction, they will take them to the treatment center, or their behavioral health crisis, they will take them to the treatment center, which is a healthcare facility, but not the emergency program.
I know we're winding up. One thing I just want to make sure, you heard post and most around a lot, but it's really important to understand your state regulations because not all of them honor those. So Wisconsin does not honor that. Only a DNR and only 18 and above. So if you have pediatrics. So as a medical director or a health system, you need to understand how to navigate through that. So that was my last piece too. Yeah.
Yeah, sorry, one last question if we have time. Do you know if there's any movement with CMS to change some of those reimbursement structures?
There actually is. Some agencies have been able to apply for a waiver to treat but not transport and still get reimbursement. So I think CMS is in trial to do that. Again, if they're able to go to an alternative destination instead of the emergency department, then they get their transport fee, right?
So the Centers for CMS put out a pilot program. We were one of the recipients for this ET3 concept, emergency triage, transport, and treatment and transport. That happened perfectly just before COVID, and it flopped. And CMS shut it down. We haven't seen a new version. So I know there's interest at the federal level. It just hasn't happened yet. I believe that's probably it. So thank you.
Thank you.
Thank you.